Good evening, everybody. Welcome to the Telstra Customer Insight Centre. Thank you so much for joining us. I'm going to hand over to Claire. She's our Deputy CEO and Director of Research, Translation and Commercialisation at Digital Health CRC. She's based here in Melbourne and is currently working with the entire CRC team, and we're very blessed to have her. Claire oversees the research and development program, the translation and commercialisation of our projects and our outputs. So please make Claire feel very welcome.
Thanks, Sam. And I don't know, it's a weird time. Is it good afternoon? Is it evening? But welcome, everyone. I'd like to start with an acknowledgement of country. So I'd like to acknowledge that we're meeting today here in Melbourne on the lands of the Wurundjeri people of the Kulin Nation, and I pay my respects to their elders past, present and emerging. And I also extend my respect to any Aboriginal and Torres Strait Islander people who are here with us today. Before I really kind of kick off on the formal things, I thought I'd also just say that tonight's event is primarily focused on gender diversity, but it's important to recognise that gender diversity is only one component of a diverse workforce, and age, cultural background, ability, race, religion and sexual orientation are all just as important. And I think having just given an acknowledgement of country, it's also important to recognise that genuine inclusion of Aboriginal and Torres Strait Islander people in all workforces, including digital health, is a vital step towards reconciliation and closing the gap between Aboriginal and Torres Strait Islander people and non-Indigenous Australians. So, but let's begin. So on behalf of the Digital Health CRC, I'm really excited to welcome you to this event. It's our inaugural event in our new DH Expo series, and I'd also like to say a special thanks to Telstra Health for collaborating with us on this first event and for hosting us here in their Customer Insight Centre. Tonight we're going to hear and discuss some of the findings from a collaborative research project that was supported by the Digital Health CRC. So capacity and capability building are key focus areas for the CRC, and when the wonderful Professor Kerryn Butler-Henderson first came to me about the CRC supporting the 2023 Digital Health Workforce Census, I was immediately on board. And as you can see from the long list of organisations I'm about to read out, they were also involved in the project. Many others recognised the value of this research. So the census project was truly an example of cooperative research. It involved Telstra Health, RMIT University, the University of Melbourne, the Commonwealth Department of Health and Aged Care, the Australasian Institute of Digital Health, the Australian Library Information Association, Health Libraries Australia, and the Health Information Management Association of Australia. So it was a real team effort. So to start tonight's proceedings, it's my pleasure to invite Professor Kerryn Butler-Henderson and Dr. Salma Arabi to present on gender diversity in the specialist digital health workforce. Kerryn is Professor and Head of the School of Nursing, Paramedicine and Healthcare Sciences at Sturt University, and has more than 20 years experience working in health and higher education with a particular focus on digital health, especially implementation science and workforce research. Dr. Salma Arabi is a rising star of digital health research and recently joined Sturt University as a Head of Discipline Digital Health. So over to you, Kerryn and Salma, and please join me in welcoming them to the stage.
Turn my mic on, and I'm assuming that's going to work. Thank you so much for the wonderful introduction. It really is a pleasure to be here for this event, this inaugural event, talking about a topic which is one that's very, very close to not only my heart, but my mentor, Professor Kathleen Gray, who you'll hear on the panel as well. That has been something that we've been doing for a long time together, and you know, with that particular focus on gender diversity, it is just such an honour to be here today to be able to launch this report with the Digital Health CRC, Telstra Health and many other partners. So what I'd like to do today with my wonderful colleague, Dr. Salma Arabi, is talk about the the digital health workforce census that underpinned the report that we are launching here. We would also like to acknowledge the traditional owners of land, both here where we are meeting today, so the Wurundjeri people, the Wurrung and Burrong language groups of the Eastern Kulin Nation, but also recognising that we have many people joining us online tonight. So I'd also like to extend that recognition to all lands across Australia and start with Woomandika. I also extend that acknowledgement to anyone in the room that does identify as a First Nations person. And I'd also like to acknowledge the fantastic funding that actually underpinned this research that we did in 2023 with all those wonderful partners that Claire mentioned at the start. Charles Sturt University was not one of the funded partners of the project that was funded through the Digital Health CRC, but we do acknowledge that they have supported both Salma and my travel here tonight to be able to be here and launch this report. So before I get too deep into talking about the report that we are launching, I want to step back a little first and talk about the specialist digital health worker. Now, this is not the workforce where the primary function of that workforce is delivering patient care. And it's not the workforce where the primary function of that workforce is health service management or back of house sort of functions or for example, accounting or catering or, accommodation type services. This is the workforce where the primary function of their roles is related to health data, health information, health management through a range of functions, including managing the data, analysing the data, governing the data, evaluating the data, the information and the knowledge. Now, stepping to the side for a moment, we also acknowledge that there is a lot of work that needs to be done within that digital literacy and digital health literacy of the broader health workforce. And I'm so honoured to also have in the audience further back is Dr. Gabriela Isabel, who is here from Barcelona, who did lead a project with RMIT University looking and developing the global atlas of literacies for health. I do make mention because she is here tonight, and anyone that's really interested in looking at that literacies piece, she is an expert on the topic, and it was a great project that we did. But we're talking specifically about that specialist digital health workforce. Those elements, those people working within those roles to be able to support the health data and health information and health knowledge. And we have no data about this workforce. In fact, the idea of a workforce census started back in 2015. We'd seen from Health Workforce Australia this report around the health information workforce that said we needed to both delineate, so we needed to be able to define as well as count who is in this workforce, and no one else was doing this work. So Kathleen and I took upon ourselves to do this. And we ran the census 2018, 2021, and then most recently 2023. So we're really starting to gain some good insights about the workforce over this period of time. You can see the numbers from the screen about participation in the workforce census. Now, what proportion of the workforce is completing the census? We actually don't know because we don't know how large this workforce is. And every time we complete the census, what we start having emerging is more and more other areas that self-identify as part of the specialist workforce. And this is really important for us because we started back in 2018 with these 6 groups that had been identified by Health Workforce Australia. And now our list is up to 21 different occupational groups that self-identify as part of the workforce. And if you use the QR code, you can go to the full census report that will talk around those 21 areas. And Salma does also have a slide that talks a little bit more about those occupational groups. So that's the broad census. We conduct it every 2 to 3 years. We really are trying to get more and more participation in it because it's the data that we get from it can really inform wonderful things like what we're talking about here today. So this is just some very high level statistics that came out of the demographic data from the 2023 census. Now in 2023, we did extend the census to be a global one. I've taken out the international data, and what you can see here is the results from 870 Australian participants. Now, part of the challenges we have with the workforce census is getting people to participate and complete it. So you can see when you look at the map of Australia, there's much heavier participation on the east coast than is elsewhere in Australia. And that's just to do with, our networks and being able to get the word out more about the census. But then once we start looking at the data itself, that we're able to make some generalizations from it, we're able to compare it against some other workforce type sources of information to be able to understand, some key things in this workforce. And the most important one is that whilst this data shows that we have a much older workforce, and that's a predominantly female workforce, when you then break it down into those occupational groups, that's where you start seeing different trends. So when we look at those that identify as a health librarian, a clinical coder, and to some extent, a health information manager, we do find that they are an older female identifying workforce. But when we look at those that identify as health IT, health informatics, data analytics, AI, cybersecurity, you're starting to see that very technical side. They're much younger and much more evenly distributed between males and females. I think it's 55% identify as female. And then when we start breaking that down further, to be able to understand the background of the women within that identify as part of those occupational groups, it's predominantly women that come from a nursing background, which we know the nursing workforce is predominantly female. So this is where this time for the 2023 census, it was really important for us to partner with Telstra Health, who had previously undertaken a workforce survey looking at gender, and being able to build not just on their data items from that previous survey and incorporate that into census, but also build it into, the census questions that we had to be able to get some richer insights into, what's happening with gender across this workforce. So again, using some of those data items from 2021, as well as our census data, we were able to analyse this and have a look at a number of different elements within the workforce, and the report, as we mentioned earlier, will be emailed to you in the coming days. But what we're providing today is just a snapshot, a high-level snapshot from that report. And then we're going to go into a little bit deeper on some areas that aren't in the report that we feel might be of interest to you. Just some really key highlights from it. When we look between the last Telstra Health report and then this one, that we have seen an increase in the number of women with more than 10 years experience within the digital health workforce, so they're staying within that workforce longer. Why that's really important is because across Australia, digital health has largely been viewed as a project or a time-limited type activity, and not necessarily something that is invested in for a long period of time. And so people quite often will be pulled out of their job to be able to work on something and then return back to whatever their role was. By seeing that women actually identifying it and in these roles for longer, it means they're actually these roles are set up as substantive positions, a longer term investment in digital health. And that's what we want, across workforce, not just at a gender level, but just investment in digital health across the sector. But then when we started looking a little bit more deeper around these aspects, for example, about whether their managers care, and I'm going to show on the next slide some numbers around this, as well as that support for gender diversity, that's where we're seeing some really interesting trends, which aren't just localised for this workforce, but when we look across the literature, we're seeing it within other workforces as well. So as you can see, and this is probably, it's not that bad on that slide if your eyes work a little bit better than mine, that some of the trends we saw within this data, this high-level data, was, for example, if you look down in this bottom corner, you can see 97% of women believe that more progress is required. Whereas when that was asked to someone that identified as male, 1 in 10 actually identified that they believe that no more progress was required. You can do the calculations to work out how many that actually works out in terms of numbers. What it does highlight is we need more numbers to be able to get some really meaningful insights from this. But the other ones are just over here on this right-hand side. is, for example, and I'm looking this way because I cannot see up on the back there, that in terms of organisations actually caring about whether this is an issue or not, again, 31% of women actually reported that they believed that their organisation did care, quite a significant lower number. In terms of being able to reach senior levels, again, women were less likely to report that that's something that they felt that they could achieve. And then, well, salary. Salary is always the hot topic. And in fact, this is one of the areas that Salma and I took a little bit more of a deeper dive into that we want to be able to share today. So what we did is we looked across two particular areas. The first one was around education background for gender across the workforce, and then the other one was around roles. So I'm going to talk a little bit about education, and then I'll hand over to Salma. One thing I do want to note, and it goes back to what Claire said in her introduction at the start, we did not have enough data to be able to draw any meaningful conclusions around our First Nations workforce. And in terms of the intersectionality in our workforce, that was something that we really, is important to us. And for our next census, we will be aiming to try and get more data, about that part of the workforce. So just noting that's one area that we weren't able to report on. So gender and education. When we have a look at who has a formal qualification in digital health, you can see from the data that in fact more women reported that they did have a formal qualification than men. So what that tells us is women are more likely to require a qualification to be able to, in digital health, to be able to get a role in digital health compared to a male applying for a digital health role. But then if you go back and consider what I talked earlier around the differences in those workforce for the occupational groups. So those roles of health librarian, clinical coder, and to some extent health information manager are very long-term, occupational groups that have been around for a long time, which has a professional requirement for a qualification to be able to do those roles. Whereas when we look at, other areas, for example, health informatics, I've been running health informatics degrees for nearly 20 years, and the number of people I have coming into my degree that say, hey, I got a job in health informatics and now I want to know what I need to do, says to me that, this might not necessarily be a gender specific, it's just, the growth or the age of that particular occupational group. So then let's start breaking it down into more detail to be able to explore this. And you can see it's at a significant level. When we had a look at the type of qualification that males versus females actually held, that males were more likely to hold a postgraduate qualification if they did have a digital health qualification. Now, it has been remiss of me to acknowledge that we did have some people that either identified as diverse gender, so they were either agender or they identified as preferred not to say. And we had such a small number of them that we excluded them from the analysis because of just making sure we protect their identity by not reporting such a small number that could potentially be identifiable in the data. So that's why you're receiving a very binary view on gender, but we recognise that there is more than just male and female. And again, it's an area that we do need to gain more data with. So then when we wanted to start looking at that intersectionality element, one that we were considering was cultural, and we have the data around country of birth. So when we considered about education, a qualification in digital health by gender as to whether their country of birth was Australia or not, we found that there was a high proportion at a statistically significant level of men employed in digital health roles who had a qualification that were Australian born, whereas that was born in Australia or another country, whereas women were more likely to be Australian born. So what that's telling us is that women that are born overseas that have a qualification in digital health were less likely to be employed in a digital health role. Disability, people living with a disability, unfortunately, whilst, it did come up with, it didn't calculate any sort of statistical significant result, it's probably because, again, the numbers were so low for us to be able to draw any inference, but I include here because you can see the pretty colours show a little bit of a difference between the two. But this is where I'm talking about the fields of education, where they actually have the qualifications from. So again, those much more traditional occupational groups is where we didn't see so much of a statistical difference between the gender. And in fact, there was a few interesting things. So for example, health librarianship, you can see, even though it's 0.044, it is a workforce that is predominantly female. So this is where we saw the skew the other way, where it was mostly women. Whereas if you look, for example, I was really interested in the health AI one. Again, that was predominantly a male workforce. And this is what I was talking about before. It replicates what we're seeing in some of the other sectors around gender with what educational background they have. So the last thing is around the remuneration. And what this here shows between the left and the right is when we add education into the mix, someone that identifies as male who has a qualification in digital health is more likely to receive a higher amount of salary than than a female with a qualification. You can see that by the distribution of male versus female as it's going down here, whereas once we took educational qualification out, there is still a difference between the two, and the report goes through what that difference is, but you can see it does even out between the two through there. So what that again is saying to us is that where someone does have a qualification, that a male was being paid at a higher rate than a female was being paid. Now, this is across the entire workforce and not broken down by occupational group, and that would be the next step that we would look at to be able to see if there's differences across those occupational groups based on salary. But just there on the high level, there was a significant difference between each of them. So that was education. I will hand over to Salma about occupational group.
Thank you, Kerryn. Hello, everyone. So hopefully you don't have any graph fatigue, because the next couple of slides are pretty graph heavy. But what we wanted to do when we started looking at occupational specialties and understanding the association between gender and the roles of people within the specialist digital health workforce was just to get a feel for the distribution of the data. So what we saw was that in an executive leadership style position, over 1/5 of that category was dominated by men, whereas it was less than 15% of that was occupied by women. Similarly, when we looked at management roles, we started to see that men accounted for over 22% of that category, whereas women were sitting more so around that 12 to 13%. So from that, I started to notice a bit of a story that was coming out of the data, and that was a bit of a disparity between gender and executive leadership and management roles. I started to notice things like women holding 19.7% of the health librarianship roles compared to just over 5% of men. And then similarly, clinical health informaticians, it was predominantly women again at around 21.5%, and at just 10.4% of men. So it was starting to indicate that there was a little bit of a trend towards men dominating roles around leadership and any type of technical position. So when I was looking at this data, I was starting to notice that women are being more drawn towards supportive roles. So roles that are more around, administration, things that weren't necessarily technical or engineering or any type of leadership positions that were typically being occupied by people that identified as male. This was reflecting a bit of a broader societal trend regarding, traditional gender roles, but I wanted to understand a little bit more. So we dug a little bit deeper and started to look at what were the major groups, what were the role titles that people were putting into the census, and how is this affected by gender. So again, in terms of management and leadership, we saw that there was slightly more male respondents that identified as managers, but nothing too significant there. But we did notice that with the professional category, it was a little bit more even. When we looked at those occupational categories a little bit more closely, we started to notice that women were occupying roles in community or personal services and administration, and were actually about 5.3 times more likely to occupy those roles when compared to men. And men were predominantly in roles around sales or, again, those technical fields. So this, unfortunately or fortunately, depending on what side of the fence you sit on, was not a shock, because similar findings were actually presented last year in the Workforce Gender Equality Agency report. We saw that roles such as, clerical and administrative workers and community and personal service fields were occupied predominantly by women, whereas CEOs, technicians, machinery operators and things of that nature were more so occupied by men. So if you look to this side of the slide, we also asked respondents in the census to manually type in their role title. Those were then coded and analysed. That was quite a strenuous process, but we got there, and we have these pretty little word clouds to show that females predominantly identified as health informaticians. That was the main role title that emerged from the data. Whereas for male respondents, the main role title was something that fell into the bracket of executive leadership. So it was, again, that same narrative that we were pulling out. And this data was just starting to kind of reaffirm that we see men dominating those leadership roles, and we see women falling more into those administrative supportive roles. So we also asked respondents to identify which Australian Digital Health Agency profile they identified with. And for anyone that doesn't know, and I'm going to read off the slide out of respect for the ADHA, the digital profiles are structured role profiles that are designed to clarify the expectations of the health workforce regarding digital health technologies. So what we saw was a statistically significant association between gender and a couple of the digital health profiles. So this included business administration and the clinical support profile, clinical and technology bridging, and education and research. So what this is telling us is that there are trends that show that specific genders, for one reason or another, are leaning more towards one of these fields as opposed to the opposite gender. We saw that women were starting, again, to be more concentrated in that business, admin and clinical support profile and education roles, whereas it was men who were more involved in the clinical and technology bridging. We then went a little further, and we asked respondents to list at a maximum of 5 functions that they perform in their role. The respondents' functions were, again, coded, and we grouped them into 15 categories that you can see on the screen, noting that one of the categories was an other for miscellaneous functions. We then went on to analyse these functions to continue to understand where there was a significant or nearing significant association with gender. And what we found was that there was a significant or nearing significant gender association across several of the functions that respondents identified. Functions such as clinical and health services, digital health and strategy, governance, technical support, project and program management, all emerged, and showing those notable differences between gender representation, suggesting, again, that certain roles may be attracting one gender or being more accessible to one gender as opposed to the other. Now, it's all good and well to know all of this information, but what are the implications of all of this information, all of this research that we've done? What do we do from here? So first, what we believe is that we need to make digital health education mandatory. We want to do this especially for specialist roles because it'll ensure that every professional is equipped with necessary skills and knowledge that they need to perform their roles to the best of their ability. Next, we think that it's really important and on brand with tonight is that we think that we need to start to tackle those barriers that are stopping women from being able to enter those technical roles. We want to be able to see some type of initiative or like implementation of an initiative that will actively encourage the participation of women in these technical roles. And finally, and touching on what Kerryn said, we want to consider intersectionality in our approach. Factors such as First Nation status, disability, and migration status can create additional workforce gaps, but we want to acknowledge that these complexities are crucial in our efforts to build what we hope will be a truly inclusive workforce. Thank you so much. I've been Salma. That was Kerryn. And this was our census data.
Thank you.
Thank you.
Oh,
I don't know if you need this. Okay.
Thank you.
Great, thank you.
Thank you, Kerryn and Salma, for a great presentation. I think you gave us a lot of food for thought there in terms of the state of the workforce today or a year ago. And just going off piece, but will there be a 2026 census?
Maybe even 2025 census.
Watch this space. So I think that's a really good introductory presentation that we can now move on to the panel session. So without further ado, it's my pleasure now to introduce our four amazing panelists for this evening's discussion. I'll start with Professor Kathleen Gray. Kathleen is Professor of Health Informatics at the University of Melbourne and co-led the census project with Kerryn. Kathleen has over the last 3 decades worked across health professions and information disciplines developing digital health education in Australia. Nice to be here. Amy, please join us on the stage. Amy is the Chief Digital Health Officer at Alfred Health, Amy McKimm. And Amy's responsible for supporting Alfred Health through its digital transformation and has worked in clinical and operational roles in health services in Australia and the UK. I'd like to welcome Malcolm Pradhan. Malcolm is an adjunct professor of digital health at the University of Sydney, and he was founder and chief medical officer at Alcidion and has more than 25 years of experience in health informatics and AI. And last, but definitely by no means least, is Carolyn Lewin. Carolyn, as of today, is that right, Carolyn? Is the new head of Telstra Health's National Cancer Screening Register. I was excited too. She oversees key operational activities and is passionate about fostering a culture of continuous improvement. So I thought a good place to start is actually to tell us a little bit more about yourselves. And also, what does a diverse digital health workforce mean to you? And I thought, given that we've just heard that you've got a new job, Caroline, we'd start with you.
Still trying to figure it out. Caroline Lewin here. I identify as she, her. And I'm going to start this a little bit differently with a reflection that if you were to ask me this question 10, 15 years ago, my answer would be very different. I'm a white female, middle-aged, being nice, but, you know, kind of there. And I've had an easy run at life. I've worked in great organisations. I've been respected. I've been supported the way through it. And I suppose you bring that perspective into everything you do from here on in. But I have had a couple of life events have occurred that have actually made me reconsider the lens I bring to things and has opened up a different way of thinking. And that's been incredibly positive for me. So a couple of them are, first are kids. You know, there's nothing like opinionated, educated young women to change your perspective and to challenge your thinking and your conversations. And they've been really powerful. They've been really, really powerful for me. The second, something that really shocked me was the discussion around gay marriage. I couldn't actually believe the vitriolic, the hateful talk that came around that. And I realised that the world is not as safe as I thought it was, and people have challenges that I'd never considered and burdens to bear that are just unacceptable. The next one was really large for me, which was the abortion referendum in Ireland and how it split the country. And again, the language that surrounded that was just abhorrent. And I'll tell you a wee story on that one. I rang my mum as that was happening, and she wasn't home. I rang her back. Where were you? I was at Mass. Okay, Mum. I said, how's the referendum going? She goes, oh, I think it's going to get up. We're going to pass it. I said, oh, how do you feel about that? And she said, well, isn't it great? Who am I to tell any poor unfortunate what to do with their life and what decision to make? And if an 88-year-old woman can actually broaden her mind to do that, surely we can all take the same sort of journey. The last life-affirming kind of learning for me was I took over the operations space in the NCSR a couple of years ago, and it's probably the most diverse area in the organisation in terms of gender, in terms of age, in terms of culture, in terms of anything. And it's been amazing. Just the conversations, just the interactions, and just the learning curve that I've gone on. So for me, this is all about understanding the world we live in today. Don't bring your previous biases to the world that we're in. Be prepared to change and grow, and listen to the team, because it's just great. And the diversity and the different ways of thinking and the different perspectives that they bring adds real value to the organisation. I was given a piece of advice, and I will stop in a minute. I was given a piece of advice a number of years ago by an old boss. I was recruiting for a role, and he said to me, "Caroline, don't hire in your own image." And I was actually quite horrified at the time. And I reflected on that, and it really is about ensuring that the team you have is totally diverse, is made up of different people, different thinking, and your job is to create the environment that they feel safe to think and talk, and they feel safe coming to you with different ideas. So I'm really excited about this role because I have a great team. They're not in the slightest bit afraid of me. They're very willing to share their thoughts and views, and I think together we're going to be better. So that's me.
Wow, thank you, Caroline. There's someone who told me just half an hour ago that they didn't have it.
Okay, right.
So interesting. That was a great start to the panel discussion. Malcolm.
Thank you. Yes, my name's Malcolm. I originally trained in medicine many years ago, and then quickly realised that my biggest contribution to patient safety would be to stop seeing patients. So I then moved into informatics, and I did a very technical PhD over in the US. And I've had really the privilege to work with many varied teams across multiple countries in developing and delivering IT solutions, but also looking at health system design in academics, in development, with clinicians, with administrators. So it's been just a wonderful experience to be able to work in those areas in very different settings as well, from rural Australia to very poor parts of, say, in the UK. And the importance of diversity, I think, is to me really about reflecting the community that we're trying to serve in all of those angles. And it's about really related to equity of the system that we're trying to build. And we know that it has not been equitable. We know the data. And so in digital health, we're in the very unique position of really setting up the infrastructure, the design, the development, the implementation, the maintenance of the infrastructure that's driving future healthcare. And for that to be equitable and to respond to different models of care and engagement to different parts of the population, particularly currently those who are underserviced, requires a diverse workforce. And I think that's a very, it's very important, not just for the ideas that come out, but for the future of the populations that we're trying to serve.
Thanks, Malcolm. Amy.
Hi, I'm Amy, a Chief Digital Health Officer, but began my career as a speech pathologist, and 99 of our 100 students were female at my university course. So it's been an interesting transition for me, going from a very female-dominated workforce, and healthcare generally is largely female-dominated, and some of the statistics we see here are very similar across our other groups of, our junior workforce being quite female. As we go more senior, we start to see a bigger differences. Look into that. And I had a couple of interesting experiences. One, my mum told me speech pathology would be good because it'd be easy to have kids, which almost made me unenroll. And then the second one was my epiphany is when I went to a diversity in tech awards night. I was privileged to be asked to come along, and it took me about 10 minutes to realise that I was the diverse one. And I was like, what do you mean? Oh, females, we're diverse. And I think there's really something about the language of diversity, and we had a discussion at work a while ago about our, I think it was called our equity and diversity group. And that is now our equity and inclusion group, because even using that terminology starts to say there's differences. And whilst I think it is important to acknowledge difference and try to actually craft around that, it's actually equally important to acknowledge the commonality and the inclusiveness of that. And even as I said, even being at that awards night, I found it confronting that I was considered a diverse minority. And so I think there is something about that, about the language we use and how we do identify that while supporting that inclusive environment.
Thank you, Amy and Kathleen.
Hi, everyone. Kathleen Gray. I'm a professor of health informatics based in the Centre for Digital Transformation of Health at the University of Melbourne, and I'm pleased to see some of my valued colleagues here today from the centre. How I got here, how do you get a job like this? I was a hospital librarian, setting up a teaching library in a rural hospital in the era when 500 internet searches of Medline a year was a big stat for the biggest health library in the state. So you can see that my information interests have come a long way. I also became an innovator in online education in the field of environmental science, in an environment where people teaching health professions wanted to know what I could do for them. So that's been my path into the position I hold now. And my particular interest in diversity here today is, as Kerryn and Salma have explained, my concern about the specialist digital health workforce. One of my concerns. We can hardly see it. It's almost invisible to most people who think about health workforce. It's pretty incohesive, sometimes incoherent. And we are concerned to find out more about it, including the research that we have done to reveal the diversity flavors that Kerryn and Salma have talked about. And to do more to improve its professionalization, to make sure that there is more self-regulation and more recognition and reward for people who do this work, who come from all sorts of backgrounds, because we think it's in the interest of getting the most out of digital health.
Great answer. Thank you, Kathleen. And I did want to kind of lean into that, what we heard from Kerryn, around this divergence in the digital health workforce where there are older women being overrepresented in those traditional paper-based kind of informatics roles, whereas the tech and data science roles you're seeing, are prominently held by younger men. Malcolm, you're looking at me sideways, and I am going to throw to you because, obviously you've worked in this space for a long time, but I also know that your daughter is doing a Master of Informatics now, and has that changed your perspective of that area of digital health?
Yes, so thanks. My daughter's almost completed a physician training, but perhaps because of my bad influences, decided to do a bioinformatics degree. She's over in the US at the moment, and one of her first meetings in joining the team that developed Neutron, which was NYU, New York University language model, was confronted with this younger male programmer who's a medical student, so under sort of special, less specialized than her, but was very defensive immediately and asking her, just throwing that. And so she found that really quite confronting because she's trying to join a team, etc. And I think it's reflective because I think the challenge, and this really had me thinking a bit about the attitudes, particularly of technical teams and that culture, because there is quite an attrition of females who stay in that technical side, and I think there's a challenge with how do you, it's all right in recruiting people and getting people into the system, but then how do we create the culture for making sure that the type of discourse and the types of discussions that go on are appropriate and are allowing those people to engage and make best use of their skills, because it's not just about having a percentage and a number, but are you actually getting people to engage actively and not be put off and leave the profession? And I think that just highlighted to me that cultural issue, and it happens in meetings because there's stand-ups that can be quite confronting about going over that, but there's a hidden layer in what's called the pull requests. In other words, of the code that you submit, and people comment on that. So there's a hidden layer to management which goes on, and if you want to Google hostile comments and pull reports, it's a whole thing, because so this happens at a very visible and invisible parts of the whole process. And I think then as machine learning and AI becomes more part of the system, and we know that it's built on data that's biased, we're going to rely on appropriately diverse workforce to make sure that these systems don't follow that, transfer that bias into healthcare delivery. So yes, it is. I think it's a significant problem that I've seen in many organisations that I've worked with.
I'll come back to that bias, but Amy, I wanted to ask you, because you kind of buck the trend that we saw here. You have an executive role in digital health. So what's your perspective of that data and your experience at the Alfred?
Yeah, so I think it's interesting that I think digital health is probably seeing more females starting to come into leadership roles, but particularly via the clinician route. And so I'm seeing less of that pure tech workforce and more of that clinical workforce starting to influence the digital health workforce. And that was obviously my experience. And certainly I think females are more likely to go for something or go for that next job if nudged versus actually seek it themselves. And that's not in our profession specific, but that's what we see. And my experience was very much a, come on, you can do it. And I was like, no, I can't. And it was like, well, you're going to. And off we go. And I think that is certainly a difference that we see. And I think but it comes down to even that student group. I was seeing lots of nurses coming to digital health and doing amazing work, but we're seeing less of that pure technical skill set being female. I was talking actually to one of my staff members a while ago who's just retiring at 73, I think she is. And she's a coder from way back. And she said when she started her career, actually a lot of women were doing that sort of work because it was actually lower paid work and it wasn't seen as that valued. As the value of that work has risen, actually the male workforce has risen with that, and we're seeing less females. And so she was sort of responding to that, which I thought was quite interesting.
Kathleen, you kind of already commented on that, but what do you have additional reflections on?
Yeah, look, I would like to take the chance to reflect more broadly on what we want from our health system. I tend to look less at clinical care settings and services and more at the level of national and global health system performance and the major human health challenges of our time, many of which have determinants that are social, cultural, economic, and environmental. And I think that we would benefit in digital health from increasing diversity of participation from all kinds of areas of the paid workforce and also the unpaid workforce in the health and care ecosystem, much of which is female, to get at some of the closer to some of the root causes of the things that land people in hospitals and stress the healthcare services beyond their all measure to sustain.
That is a wide net. But I think in terms of just going back to that comment around diversity versus inclusion and how you can promote diversity through inclusion, how does that work in practice? Do you have examples of that, Caroline?
Yeah, well, we have a number of programs that, we have a number of programs that support that. So our, our recruitment project, our program is very wide and very balanced, I would think. But once you get people in, it's really the role of management to create a safe environment and to create a balanced and fair environment and a forum for people if they have concerns to air them, because it's hard to find good people. If you find good people, the last thing you want to do is have them leave the organisation for issues that could be resolved if they had the courage to speak to you about it. We're lucky we have a Spectrum program that actually supports the LGBT community. We have Vibe. There's a number of things, but it goes back to mentoring. It goes back to that safe world.
Culture, I think.
It is culture, and we've had some really interesting trends, because you sometimes only get one chance to get it right. So it's how you treat the first employee within a certain area. So we've had a number of gay people inside our contact centre, and I think they've been treated with respect. And we've recruited so many people through word of mouth. So you know you're doing something right when people tell their friends this is a good place to be and it's safe. And there was a very simple learning, and it's often the little things that make the difference. In our training world, our training manager, when she's getting people to introduce themselves, she goes, your name, a little bit about you, and what pronoun you'd like to use. People immediately feel that that's safe. And if that's happening in training, then there's an organisational support for inclusion. If there is a problem, the organisation will support you. And that's the sort of thing. It's the subliminal things. It's the execs leading in a way, because each of the execs support some of these groups that we have. And I think that's really important to create balance and safety.
Amy, you talked about getting the nudge. How do you practice that in a generalised, scalable way?
Yeah, so I was reflecting on what do Alfred Health do and what do I personally do, and I think it's appalling. We're not good at it. I think that the comment about don't employ yourself, as my sort of surmise of Caroline's comment there, was one of the things I'd thought about coming today, and that's the biggest thing I do on an individual basis, is really challenging myself in that recruitment role of who am I recruiting? Why did I connect with that person? And it takes me back to some theory somebody did at one stage. So that's all good science for you. And I remember doing it sort of one of those leadership camps, and they were like, you marry someone who's different to you, you have an affair with someone who's the same as you. And so you can all take that home with you. And what it made me think about was actually the recruitment process and who you connect with instantly in that recruitment phase, which is very short and very brief. And it's people you connect with easily that you see yourself with. And that's not necessarily the best person you need to bring in your team. And that's something that I constantly challenge myself with when we're going through a recruitment process, and challenge my staff to think about, is what is the gap in our team? Be that from a skill set or a background or a thinking mentality, to actually go, how do we bring that in? And then how do we actually work as a team to use that difference and diversity to support better decision making? And that is not easy, because I sit in meetings and I think, I'd be so much easier if I just appointed all people who thought like me and we'd get this done in 5 minutes. So I think that on a personal level, I think organisationally we've got a lot more to do about how we look at true inclusivity. And my biggest concern in healthcare is probably not gender so much, but about people who have healthcare conditions. These are the people we are creating and designing for, and their voice is not necessarily represented in our workforce to actually guide us in how to do that best. And I think we come from very paternalistic, we know best stances, and really trying to figure out how we can bring that and support people from a multitude of backgrounds with a multitude of skills, I think is one of the challenges we have.
Yeah, I mean, I think in thinking about diversity, you think about, well, the workforce should represent the population that it serves. And I think that was some of the points that you were making, Kathleen. So do you want to expand on that?
Well, sure.
Or go your own way.
Is that very open-ended? Thank you. Yeah, I mean, I think we all have to reflect on what we expect from increasing diversity of engagement in digital health. Do we think it's good enough for its own sake? Or do we have particular aspects of health system performance that we are targeting, whether that's access or equity or safety? Then we need to develop programs to try and affect those kinds of changes or meet those expectations. And I do think that program development doesn't come from nowhere. And organizations that are busy trying to deliver health services or deliver technologies and support those health services aren't necessarily able to design programs as well. So I do think that third sector organizations, educational organizations can be involved in working with other parts of the health system to develop programs. And I mean, one that springs to mind in terms of gender diversity is one that I would like to acknowledge my colleague, Professor Wendy Chapman, has done in her role as our center director, bringing from the United States a program that she built there to support women in digital health leadership, which has had a great deal of success and has helped perhaps to provide the raw material to actually meet the workforce needs that we've heard expressed here. So program development is an important part of this.
Absolutely. I mean, and Amy, you were really talking about unconscious bias, and obviously bias is quite a topic in AI and tech. Malcolm, what are your reflections, I guess, on the importance of a diverse workforce, or is it important?
Oh, look, it's incredibly important and very scary in my view, because there's so much, with the hype going on with AI at the moment, and there's so much investment going on, and so there are companies pushing products out there, and clinicians, are getting under pressure, and so hospital systems, already under a pressured system to adopt these products. Or in some cases, like one US electronic medical record vendor, they're just putting it straight into the product. And we know that it's biased, and previous algorithms like sepsis algorithms have known to be biased and put out into production without any validation. And I think, and just surveying a little bit around the governance processes, they're very immature in healthcare. I know you're doing a whole lot of work on that area. But ultimately, there isn't the people actually on the teams, and people on the front line in these teams are ending up with that responsibility to ask those questions and to observe the biases and understand, are these models and how do they behave and how they're going to affect different parts of the population. And these are based on data which we don't even often know that, where the data's come from. And we know that the American health care system is very biased, and a lot of it's been trained on that and being pushed internationally. So yeah, it's a really big concern, and I'm actually genuinely quite staggered at the lack of, I guess, shock and about this whole thing, that people are just saying, yeah, let's just plug it in and see how it goes. And that's shocking to me. And I think building from the beginning right through the whole process, having a diversity of views and making and ensuring the safety of these products in different populations, and particularly the generally underserviced populations who are in most need, that's not happening automatically, and it's going to rely on a lot of the endpoint or the receiving organisations to do that work, and we need to really have that diversity to support it. It worries me a lot.
Kathleen, you looking at me like you might have something to say?
Yeah, maybe. Yeah, I think there's something to be said here for the diversity of disciplinary backgrounds that need to go into the digital health workforce. We think a lot about the clinical workforce and enabling them, and the service users and empowering them. But I have become intrigued with the idea of an idea called One Digital Health that has come out of Europe, which recognizes that some of the key problems that we are experiencing in human health are linked to problems with animal health and ecosystem health. And we are not sufficiently developing the health workforce or equipping them with tools and technologies and data to be able to join the dots with some of these problems. And so I think that there's a disciplinary diversity that we haven't raised previously in the conversation.
Yeah, so health doesn't happen in isolation. It's part of it every day, such as every aspect of life. I suppose.
Everything is connected to everything
That
else,
is
and there is no free lunch.
I thought I'd just
Particularly in digital.
But there are drinks after this. So, is there questions from the audience? Does anyone have a burning question? I thought I might just ask, or have there been questions online? No? Kerryn?
Great. Thank you for such a great panel discussion. I've really enjoyed hearing each of your perspectives. One thing that's come up a few times, and you've started talking upon it, but we've not really explored, is that element around, our patriarchal system and how we recruit, how we retain staff is based upon some of that really old school, really supported to not necessarily support women in these roles. And the example, Malcolm, that you gave was about the stand-up meetings, and that is a very patriarchal type way of doing it. So can we just, I'm really keen to hear from each of the panelists about something that you've seen or you've done yourself that changes how we do things that might be more inclusive, that can retain our workforce, and not just gender diversity, but, across cultural, sexual diversity, culture, all of those elements.
You've stolen my question, but who wants to go first? Carolyn?
I can just speak for the organisations I've worked for, but I think we've come a long way. I think there's a long way there's a way to go as well. But things like paid maternity leave, paid paternity leave, flexible working hours, understanding that children need to be dropped off and picked up, and the working day goes from 7 till 6. Not all of it, but you can get your work done inside that. So you can actually build your job around your family and around your commitments or your caring commitments. And I think that makes a difference. People don't apologise for having to go and collect the kids anymore, and that's a really positive thing. So that sort of stuff works really well. I think there is an onus on team members and staff to come back and tell us what works for them too, and understand that there is a degree of flexibility in the workforce. As long as the work gets done, that's what's important. Not all, and the problem we have is not all jobs are flexible. So it does become a problem when you can't offer it to every team member. And it's about crafting the story to make sure that people feel what you're doing is equitable, and that there's a reason behind the decisions. And that's the communication thing that's a challenge.
Yeah, I also think looking at pay is really important. And what you showed in your study is, I think, really interesting. And one of the challenges we have is working under our enterprise bargaining agreements. And the one for Victorian digital health workers in a hospital sector is the admin award. I'm not even sure if it knows what a digital health worker is. And I think there's some really good structural work we could do about looking at our EBA. And I had a recent example, which we failed completely at, in terms of a staff member came to me who wanted paternity leave a year after his baby had been born. His wife had taken the first 3 months, and he had now applied for his a year later. And it was refused because our EBA says that needs to be contemporaneous with the birth of the child. And we've actually seen more advancements in nursing EBAs and things like that about some of those conditions that we've seen in our admin EBAs. We also find our EBA completely undervalues and doesn't look at market rates for our staff. And what that leads to is that the actual structural rate is quite low. You can negotiate a better rate. And we know women are less likely to try to negotiate salary, so they're more likely to accept that's the EBA rate than male colleagues who will actually argue for that. And there is negotiation. And I think that's, and particularly coming from a nursing and allied health workforce where there isn't really negotiation, you see a massive difference. And so one of the things we're doing is actually looking at our salary structures of roles and trying to reduce some of that sort of individualisation and trying to say this about the role, regardless of background, regardless of actually education. If you can do the job, you can do the job. And I think that's something we're looking at. But I do think we need to actually look at some of our enterprise bargaining agreements and seeing how we can structurally really support actual gender equity.
Yeah, I think going to what you say, I think we talk about digital health transforming healthcare, and that means scopes of practice, and that means models of care. So, and we also know that there are scenarios of automation and AI in healthcare, which are quite threatening to the workforce. Care bots, people being completely displaced or ending up working in call centers or in the gig economy. These are some of the scenarios that big consulting houses are putting forward as potentially the way digital health will transform care. I mean, I speak as an educator of entry-level professionals and people who are mid-career and advancing their careers. I think we need to empower people who are in the workforce, who want to be in the health and care workforce, to feel that they have a say in decisions about how technology is chosen, how it's deployed, and how work with technology is recognized, so that the work it feels worthwhile and is recognized as professional work. Otherwise, we are talking about a generally less and less appealing work to do as a result of more and more digital health.
Thanks, Kathleen. I am getting the wind up, but Malcolm, maybe a quick answer from you, and then 20 words or less, like a final takeaway.
Just on that point, I think that sort of paternalistic kind of model, there's no evidence for all of these things anyway. As you say, they're just traditional. And I think part of it is understanding the different communication styles. If you really want to extract most from the people that you're working with, because they may have language or personality or neurodivergent, whatever it is, that one model isn't going to fit it. So it's extra work to understand what are the communication styles to get the right information and engage that person into the decision making, and then kind of shepherd those ideas through, because traditionally they may not have been considered before. But if you're trying to build product or models of care that take all these different areas into consideration, that's not, as Amy said, it's easy just to do what's been done, and sometimes you go, oh man, do I have to really think about it? But it takes work and effort and acknowledging that there are different communication styles that we need to support in these often very pressured environments when you're trying to deliver some product or some healthcare service. So it is a challenge. Understanding that extra work actually yields more value, though. That yes, absolutely. Enabling people to communicate yields value. Do I have time for looking at my 20 words or less? Any final reflections?
I would just say, reflect on what your expectations are from increasing or changing diversity in the digital health workforce, and be a bit deliberate about trying to get the outcomes that you want from that.
Amy?
Yeah, the word that came to my mind was intentional. It does require intent, and how we can keep that is really challenging, but be intentional about it and go for the marriage, not the affair.
Okay, that's a tough one to follow, but yeah, it's a bit like that. It's, what is the culture that isn't just about values, but about embracing people's input and views into whatever endeavours you're trying to do, and that takes effort.
I'll try 4 words. Be curious and stay current.
That's great. I think that's a fantastic way to finish. So I'd just like to thank you all for such a wonderful panel discussion. Thank you to Kerryn and Salma. I think Sam is going to come out with some gifts just to express that thanks. Again, thanks to Telstra Health for their collaboration and for hosting us here. Thank you to the tech team to ensuring that everything runs smoothly, and everyone who joined us here tonight, whether you're online or in person. And lastly, we'd appreciate your feedback. So there will be a 2-minute survey, QR code behind me, and they'll also send a link to the recording in the coming days. So thank you, everyone. And for those of you here in person, please join us for networking, drinks and canapés outside. Thank you.